once again. Now, Professor Vlachopoulos.
It is my pleasure to introduce Dr. Dimitris Klέτtas. Dimitris is well known to you UK citizens because he had a remarkable career there, and he continues his career in Greece and in the Caribbean also, so he's a true citizen of the world. As I know, he will present two cases, one with a solved problem and the other one with an unsolved problem. But Dimitris, you have to be very, very short because we have run out of time, so it's up to you, an experienced speaker, to reduce the length.
Thank you very much. I will do my best about the length of my speech, Professor Vlachopoulos. I would like to say big thanks to the organizing committee for inviting me here today. So yes, as you said, the two cases. The first case is shorted, but the second is a big quiz. So I will need the help of everyone here in this room. So let's move on. The first case. The first case is a female, 48 years old, with mild shortness of breath and mild pedal edema. No previous cardiac history. I am the one that I performed a cardiac MRI for her. So this is the first thing that I saw. It was a normal LV function with relatively normal structure, and you can see that the LV wall thickness is normal. You can see it visually, but even if you measure it, it will be normal. So I'm going a little bit fast, sorry about this. And then in the MRI, obviously, as it was shown in the echo as well as AR, aortic valve regurgitation. And this aortic valve regurgitation was a bit mild to moderate. So there was, I mean, it was unlikely, severely unlikely this to cause the symptoms, but we just notified it. So after that, this was the ECG that she had. So this ECG showed some mildly reduced voltage in the precardial leads. However, it was not, like the most ever low voltages, and a kind of Q wave in the V1 and V2. Sorry about the name. So the thing is that, the LG images, that was actually the core of the study of, of this presentation. So she had the MRI, we had the, we have done the MRI. So in the MRI, the only abnormal finding was this small, yeah, we can do this. So was this small here, bright focal LG enhancement, and that you can see that it's the mid-myocardial space, so it's not endocardial, it's not epicardial. So what we said, what we actually suspected was that probably this was a myocarditis, because the wall thickness was normal, everything was normal, the systolic function was normal, was this mild abnormality there that looks like myocarditis because of the extent and because of the location, and due to the location. So after that, 6 months later, the lady still has severe symptoms. So, and with no changes in the LV function, worsening shortness of breath, no symptoms of chest pain, and no ECG changes. So she was referred for an echo, and the echo was like this. So it was 6 months later. I repeat, 6 months later. So you can see that it is a concentric hypertrophy all over the place. The walls are thick, 18 millimeters, and you can see that it is mildly normal or mildly reduced systolic function, as you can see it visually. And she was referred for a second MRI, and the second MRI showed this image in 6 months. So I think that it is very obvious, like for the majority of the audience, but you can see that the myocardium should have been black, and you can see that there are everywhere, endocardial, epicardial, midwall, everywhere, late gadolinium enhancements, many places, all over the place. So this would be highly suggestive of amyloidosis. But after that, and these are the maps. So normally you can see what are the normal values. The normal values would be highlighted with the yellow color. And you can see that this is the bullseye, okay? And you can see how the ECV is very high with red color and the myocardium everywhere. Okay, so she had a PET scan, and the PET scan revealed no abnormality. But after that, she had a biopsy that revealed AL amyloidosis. So the takeaway messages and the reason for presenting this case is first that despite in the patient, like the most important thing is patient's symptoms, and despite this patient had these symptoms, these mild symptoms, and we all thought that was a myocarditis because of the borderline systolic function and the mild abnormality in the posterior wall and in the ferolateral wall, it was obvious with myocarditis. According to the MRI, this could be several other, like exotic disease, like sarcoidosis or whatever. But we, as doctors, we have to think the most likely case first and then to go further to other more unlikely cases. So this looked like myocarditis, but you see that in 6 months, how rapidly it progressed and how obvious was this progressive wall thickening and progressive LG. So, and just to keep it in mind that amyloidosis is not a disease only for the elderly, because we see very often to elderly people amyloidosis. So when we see a very profound concentric hypertrophy in younger patients, we tend not to keep inside our mind the high likelihood for amyloidosis. So this was my first case. If you have any comments, please, yes. Of course, of course.
I think there are three messages that we can take out of this presentation. First one, the suspicion of amyloidosis would come first from the relatively low voltage of in the ECG. Now, from the clinical perspective, so rapid deterioration of amyloidosis is only seen in AL amyloidosis. So that was revealed with the bone scan that you did, and it was negative, so there was no ATTR amyloidosis. And you made the diagnosis with the biopsy. Now, at some point, I suppose that either the KL change or the immune fixation or the electrophoresis would have been normal. What was the cause of that? Because this is something, once you suspect amyloidosis, first you should aim for it. So was there any intermediate test done for that?
Yes, to be honest with you, I'm not sure, like if there was any other test have been done, because I was not in charge of the investigation. But I understand through the history and through my questions to the appropriate people that they have done this, that this was after, like the negative PET scan, they proceeded to this test and they found out it was AL. So normally what we do, yes, I guess that I agree with you.
Because the thing is that once you suspect amyloidosis, then you should go directly for the diagnosis of AL. We had a case similar to that, which was had negative AL signs. There was a rapid progression. Totally, the heart was so suggestive. Was diagnostic of amyloidosis, but it was not ATTR. And while we did, when we did the biopsy, at the same time, the electrophoresis and the immunofixation, they became positive. So there was a rapid progression. So we have to, you're very correct. We have to be aware of this diagnosis that is very, very lethal, very, very poor prognosis. And the ATTR has a bad prognosis, but the AL has a more grave one.
Yes.
Are there any comments from the audience before we proceed to the final case?
Should have been treatment be instituted early, because I believe the patient, she was not treated.
Yes, until like
because
the second MRI.
It's a race with the time. I think.
I agree.
Petros is right. Once you diagnose, you should directly, because the treatment is completely different.
And this is the reason actually for presenting this. Just like to.
Dr. Gossis.
Yeah. Excellent talk. One quick question is, obviously late enhancement in the early stages wouldn't have been as massive as a second scan. Did you have any changes on T1 mapping or ECV suggestive of early diffuse disease, perhaps?
That's
in the first scan.
In the first scan, yes, I understand. So it's a very good question, yes, very good question, because what you say is, okay, you didn't have any LG, so what about the T1 mapping? If there was any subtle changes there, you wouldn't see any LG, but you would see a little bit elevated or markedly elevated ECV. No, it was normal. It was normal. It was normal, and it was only that small case, that small spot. And I repeat, this small spot didn't include the endocardium. It was only in the mid-myocardium.
I made a comment, Dimitris, to Babis. In the first MRI, in the short axis, I thought I saw some more diffuse, patchy fibrosis in the LGE. Can you show it again? I don't know if another MRI expert is, but in the short axis, bottom left, I think here you can see, to my eyes, some more patchy, diffuse fibrosis.
So you talk about this one here?
No, in the lateral.
No, in the lateral wall.
Here? Yeah. And what about here?
Yeah, patchy diffuse.
And here? No. Okay, so that's a good question again, but it's a long conversation. So in these cases, when we see all this stuff here, and when this is not actually confirmed by the maps, so this can be artifacts of homogeneity of the MRI scanner. So to say in other words, if we report all of this stuff as LGE, then it would be like 50% of cases would have LGE. So this is, because you can see that even here, here you say, okay, finally it was amyloidosis, so finally after 6 months, you had, LG in many cases. So it's easy now to say that, but this is the image where we take from most of cases, normal cases. So we need actually to have something that is detected and double-checked and confirmed by cross-cuts. So wherever we see, like a bright area, we do like another section there. And if it is double confirmed, then we say it's LG. But thank you very much for your notes. It was okay.
If there's no other question, let's move.
Yes, the second case. So
the next 3 minutes to the final presentation.
Okay.
I'm pressing him a lot.
The next 1.5 minutes. So okay. So this is the case. So it's a female. Okay, so I'll try to explain you from my view and all the details, and then to make it easier for you. So this is a 60-year-old lady with sudden onset chest pain after a stressful incident. Okay, I know that our minds go somewhere. So great troponin rise, though, however, great troponin rise, no previous cardiac history, and a normal angiogram that I'm going to show you to present you the angiogram that I received this morning. It's a very a recent case, like 3 days ago. So this is the MRI picture of your first MRI last year, 1 year ago that happened, yeah? So what you can see here, I'm just making it easier. So there is edema everywhere. This lead gadolinium LG picture. So you can see here that it's gray, all over gray. You can see the wall underneath, the gray wall. And we can see also that it is either a huge LAD that is a wraparound till the base or mid inferior wall, or it is a basal wall sparing with edema to the rest of the case, like in Takotsubo, okay? So edema everywhere. So what the first thing that came to us that we thought last year was that probably this is a Takotsubo. I didn't have any knowledge, I was not aware of the troponin rise, so I saw only the picture. So what I have said was that this is not a great vessel territory. The remodeling looks like Takotsubo, the apical ballooning, and you can see that it's the same level there and there, where the edema starts and ends. So this does not follow a great epicardial vessel territory. Okay, this happened last year. This was the ECG last year. Okay, ST elevation, blah, 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 blah. Okay, so this is the angiogram she had last year. So, this is the angiogram she had last year. It's a big RCA. That I would have expected to be like smaller if it was a huge LAD. And I understand, as our interventionist friends said, that this is normal. Yes, I can't confirm it 100%, but all the small arteries of the anterior wall that are normal, okay? So
I wouldn't say that it's normal though,
okay.
because it has irregularities all over the place, and
There are.
and the distal part of the LAD is very constricted, I would say.
Mm-hmm. Yes, yes. I mean, I have just received it this morning.
Okay. This is why we're here to discuss. Okay.
Yes, yes. I have no idea actually. You are an interventionalist, so you can actually explain us if you have any. So, what about the LAD? I mean, the LAD. Can you see any?
The middle to distal part is there's a tapering, a large tapering towards the end, compared to the RCA. So this is the territory that has been affected, isn't it?
Mm-hmm. Well, yes, it was a big territory that has been affected. That's the issue here.
Okay.
So, okay, this was a coronary angiogram, and 12 months later, last week, we have an MRI with this image. So, I'm going through it just very quickly. So you can see here this ballooning remodeling that can happen in tachytubo, but can happen again, you know, like when there's a big LAD infarction. However, if you see here, so here, oh, it's me. Oh, sorry. So if you see here, there's a perfusion. So you can see no LVO, no microvascular obstruction, no microvascular obstruction. This is the early, this is a perfusion. You can see the whole myocardium has gray color. And here in the LG, there is an intermediate layer that looks black, normal. There is an inner layer that's a ischemic scar. And there is an epicardial layer as well. One could say that this epicardial layer maybe is fat, that also appears bright in this sequence. However, if you see here the cine, that again the fat is bright, there is no fat because it's the same picture here and there. So this bright layer, epicardial layer, that normally has to do with inflammation, is not fat. And there is obviously, look at here, look at this. There is an endocardial ischemic small scar all over, sparing the lateral wall. So like being a big LAD, an LAD territory here as well, but in the very apical segments. And if you look carefully here, then you can see that this apex, despite being dyskinetic in the beginning, it contracts a little bit. That this never happens when there is a big LAD infraction because it is clearly scar, 100% scar, it is completely mobile or dyskinetic. But you can see that's a small contraction here. So, and here again, you can see this epicardial layer, and then a normal layer, and then the ischemic layer. Okay? So, I have explained to you, interpreted, you know, like this MRI to give you all the information, you know, like from an MRI expert, just to know how it is. And now, I need your views, professors.
I already made up my mind, which is it's an ischemic disease of the LAD to my interpretation, because from the middle to the distal part there's a tapering of the vessel. There might be a recanalized LAD after a myocardial infarction, and the portion that you describe it in it moves, is kinetic. It might be due to the posterior descending that also irrigates this territory. So the scar is ischemic, okay, as you have shown. So to my mind, the angiogram is not normal.
Okay, so my questions to you then is you know, like the LAD till here, till the mid, till the base mid-inferior wall, so these LADs, all these wrap around.
It's a wraparound LAD.
Yeah, down there, because the wraparound normally will be down there, but do you remember the first picture? So this is my first question, and the second question is what this epicardial layer here has to do with the ischemic disease. All this epicardial inflammatory LD has to do with ischemic disease, sorry. So look here, it starts from there, ended up there. Look how big is the territory. I know this sounds like
could it be fat? Could it be fat?
No, I just showed, you know, like in that, yes, it's a good question. But here, if you notice, here the layer is bright, And when you see the cine picture next to it, you can see that no fat between the bones and the heart. So these are my questions.
Any other guesses?
Another guesses?
Can we see an echocardiogram?
Yes, we can see in a week's time.
Okay, Dr. Gossis.
It's very, very interesting, Dimitris. When you've got this ischemic pattern with myocarditis, you tend to think of eosinophilic myocarditis or intramyocardial fibrosis, I guess. Chagas is very rare in these areas of the world. Did you have any?
It could be
features?
Chagas, but it is completely controversial to the patient's lifestyle and history. Yeah.
Bolivia.
Yes, exactly. But it could be Chagas according, to the images. And eosinophilic would be a little bit different, in the MRI.
What is the origin of this patient? Is she Greek 100%?
Yes.
So we don't have an answer. Do we have a winner?
No.
I don't know.
I came here, for you to help me, not actually.
Okay.
Okay, so
we need to gather more information.
Dr. Pantazis is looking with us.
Antonis, are you're skeptical? Are you contemplating anything?
No, I'm not skeptical. I mean, that's an interesting case. I would probably do more tests because everyone died, there's no clear diagnosis. Do you have any evidence of perfusion defects in areas which are not right in the center of the depth of the akinesia, but around the akinesia? Because I agree with what you said, that the LAD doesn't look right, but would you have expected a well-defined area of akinesia and no perfusion defects around it?
This is what we call very often an out of proportion ventricular dysfunction compared to the LAD, to the coronary appearances. But my point is that the absence of microvascular obstruction in the first MRI, is that not significant? Could be. Because in MVO, in ischemic disease, you have microvascular obstruction early post-recanalization. Not to have MVO, to me, it is towards non-ischemic, but
yes.
Not
or
everything fits.
Yes, please. Yes. No, we're thinking of doing it now because it's very recent, as I said. Yes, we're thinking of doing some SPECT. Maybe give us more information. Professor, any ideas?
It seems like ischemic pattern. What do you think? Are you going to proceed in another examination?
Yes, probably we'll do a SPECT, yes, as you said. So the thing is, the first one, and what, now we have to move to more unlikely scenarios. What we thought, what I was seeing lately, Petros, is that maybe there's a combined case that after this stressful incident, this lady had ischemic event, maybe like a thrombus that was soft-diluted or something like this, whatever it is, and this actually enhanced a tachotube reaction because of the incident of the stress and of the pain that she felt. And maybe there is a combined reaction of an ischemic event that enhanced a tachotube reaction in the heart as well with catecholamines and stuff. I know that this scenario sounds a little bit more not very common, but we have to go to.
Okay, that was a very good ending, leaving us with more questions than answers.
Okay.
So that was part of the excitement of this roundtable. So thank you very much. We thank you
very much.
and we go on to the next.